صباح الخير. بسم الله الرحمن الرحيم. نبدأ فعاليات اليوم الثاني للمؤتمر رقم 26 للجمعية المصرية للضغط. أرجو أن أنتم امبارح تكونوا استمتعتوا باليوم، وإن شاء الله مكملين النهاردة اليوم الثاني. It's my pleasure to co-share this session with my dear Professor Muhammad Awad Tahir, Professor of Cardiology in Shams University, and Professor Faris Abdel Karim from Iraq. It's our pleasure to have you with us today.
صباح الخير. اولا ببدا الكلام بسعادتي بوجودي في وسطكم وشكري للاستاذ الدكتور محسن ابراهيم والاستاذ الدكتور محمد سليم على دعوتي لحضور السيشن دي في المؤتمر. ونبدا باول سبيكر الاستاذ الدكتور كريم سعيد، استاذ امراض القلب بكليه طب القصر العيني، ويتكلم على الحقيقه انتريجنج سبجكت اللي هي الوايت كوت هايبرتنشن. اتفضل.
بسم الله الرحمن الرحيم. صباح الخير على حضراتكم جميعا. في البداية بتشرف بوجودي وسط حضراتكم في المؤتمر اللي بعتز بيه دايما، و thanks for the kind invitations. ممكن السلايد لو سمحت. Okay. Today I'm going to talk about two contradictory subjects collected in one lecture. However, at the end of the lecture, we will find many similarities that share many characters in both entities: white coat hypertension and masked hypertension. Now, with the availability of the office and out of office blood pressure measurements, we had 4 patterns of blood pressure phenotypes. Of course, out of office, I mean home blood pressure measurements and ambulatory blood pressure measurements. When both techniques are concordant and normal in readings, we had what is called normal blood pressure. And when both are elevated out and in office measurements, we have sustained hypertension. However, when there is controversy between both entities, we had masked or white coat hypertension. When the office is elevated and out of office is normal, this is white coat hypertension. And when the opposite occur, when the office is normal and the home or ambulatory measurements are elevated, this is masked hypertension. And it is important to emphasize the fact that this is applied in untreated patients, those patients not on treatment. When treatment is given, we have other terms. Patients with elevated blood pressure in the office and normal at home, this is called white coat effect. And when the blood pressure is normal at the office and elevated at home in those who had treatment, this is called masked uncontrolled hypertension. So we have many terminologies that may be confusing. We have different cutoff to define what is normal office and what is normal out of office measurements. Of course, we have the 130/80 cutoff by the American guidelines. On the other hand, we have the 140/90 cutoff by the other societies. In the home measurements, the ECC offered the 130/80 still and the 135/85 by the European. In the ambulatory blood pressure measurements for white coat, we depend upon the day measurements and the mean measurements. We do not use the nocturnal measurements. For the masked hypertension, we use the day, nocturnal, and the mean measurements. We have different cutoffs, and this had an impact on the prevalence of the problems. These entities are not uncommon. When we talk about white coat hypertension, we will find that up to 40% of those patients or individuals who have elevated office blood pressure will turn it out to have normal out of office blood pressure. And this figure may jump up to 50% in elderly. While in those patients with normal blood pressure at office, we will find that up to 25% will have elevated blood pressure at home. In those patients treated with antihypertensive medications, and we are satisfied by their reading at office, 1/3 of these patients will have elevated blood pressure at home. So this is large numbers and represent a challenge in the management of those patients. What is the impact of these phenotypes on the outcome of our patients? It is thought that white coat hypertension and muscular hypertension are intermediate stage between normal blood pressure and sustained elevation of the blood pressure. So those patients with white coat hypertension, when they are followed up, there is twofold increase in the risk to have sustained hypertension in the remaining years of their lives. And the same is true when we talk about muscular hypertension. So the guidelines, all guidelines, recommend to follow up those patients regularly to pick up those patients who are going to have sustained hypertension. Also, these entities come with bad friends. They tend to have metabolic dysfunctions. Those with white coat hypertension and those with muscular hypertension tend to have high prevalence of obesity, dyslipidemia, diabetes, prediabetes, metabolic syndrome. They lie in an intermediate stage between those with normal blood pressure and those with sustained hypertension. So they have bad friends that should be considered when we risk stratify their outcome. Risk of developing of diabetes mellitus is higher also in those patients with white coat or muscular hypertension, especially when we refer to the ambulatory blood pressure measurement. It is a rule that ambulatory blood pressure measurement is more predictive and powerful to entail the outcome of those patients when compared to home blood pressure measurements. When we look to the outcome, the mortality, the risk of infarction, the risk of stroke in patients with muscular hypertension, they have the same outcome compared to those with sustained hypertension. This is a very important point, and this explains why we should treat those with muscular hypertension as if they have sustained hypertension. And in some studies, the risk in those patients is even higher compared to those with sustained hypertension. The risk is doubled when compared to those with normal blood pressure. So the outcome in muscular hypertension is grave, and this is settled in all studies. The problem when we talk about white coat hypertension, we have contradictory results. However, the majority of data tell us that this is not a malignant entity. However, some studies concluded white coat hypertension is not a benign entity when we follow those patients on a very long outcome and when we consider their bad metabolic risk profile. Some studies reported increased risk of infarction, stroke, and mortality. White coat hypertension is associated with increased risk of target organ damage, hypertrophy, microalbuminuria, and retinopathy. And again, the risk is intermediate between normal blood pressure and sustained hypertension. Why white coat hypertension can beget target organ damage? We have several mechanisms. One, the sympathetic activity. White coat blood pressure is related to increased sympathetic tone. And the bad friends, the metabolic dysregulations. And the fact that those with white coat hypertension tend to have a blood pressure that is near the upper target of the blood pressure, not 110 systolic. Usually they are 130 plus systolic. And we know the relation between the higher the blood pressure, even in the normal range, compared to the poor long-term outcome. Now to the clinical practice, how to evaluate and how to treat those patients. First, we should consider the fact that ruling in or out masked or white coat hypertension is an integral part in our management in suspected patients with elevated blood pressure. This is the flow chart or the chart table offered by the European Society. And as we know, as we can see, when we have a patient with elevated blood pressure, first we should rule out white coat hypertension. And if blood pressure is normal, we should rule out masked hypertension. And when we treat this patient, we should rule out white coat effect as well as masked uncontrolled hypertension. How to manage and how to evaluate patients with white coat hypertension. First, not all patients with elevated blood pressure at clinic should be evaluated for white coat hypertension. Only those patients with 10 millimeter above the threshold for the diagnosis of hypertension. If we are going to take the European guidelines as a standard, so the majority of white coat hypertension patients will have a systolic blood pressure between 140 to 160 systolic, 90 to 100 diastolic. So we should not expect a patient with white coat hypertension to have a systolic blood pressure at clinic repeatedly over 170, for example. Majority of patients will lie within this mild range of hypertension. And this explains why the American guidelines give class 2A recommendation in adults with untreated systolic blood pressure greater than 130 up to 160 systolic, 80 to 100 diastolic, to have a daytime ambulatory blood pressure or home blood pressure monitoring before diagnosis of hypertension. This is the first rule. Second, we should expect this white coat hypertension in elderly, in females, in non-smoker, and those patients without target organ damage. So it is not easy to rule out patients based upon these loose criteria. And if we want to evaluate white coat hypertension, we should screen all newly diagnosed hypertensive patients for the presence of white coat hypertension. And as we can see here, this is the Canadian guidelines. When I have a patient with elevated blood pressure, this is called probable hypertension. And then all those patients should have out-of-office blood pressure measurement, all of them, regardless their blood pressure, phenotypes, measurements, or characteristics. And when out-of-office is elevated, this is called sustained hypertension. The same was applied with the NICE guidelines. How to manage those patients? Of course, we should assess the cardiovascular risk, target organ damage, offer lifestyle modifications, and evaluation for metabolic alterations. And now to the golden question. Should we offer antihypertensive medications to those patients? We have two schools. The first school, not to treat. And this is based upon the following rationale. Office blood pressure is not a reliable predictor for cardiovascular outcomes. This is a fact. The best predictor is the home measurements. The majority of those patients are having mild hypertension and low cardiovascular event. So they are not going to have protection from medications. And the increased risk of hypotension, especially in those elderly patients, as well as the absence of any randomized controlled trial to support the use of these medications in those patients. However, the other school recommends that some group of those patients deserve medications based upon the increased risk of cardiovascular event reported in some studies, the presence of target organ damage, and in fact, the majority of nearly all established randomized controlled trial are inevitably included good proportion of patients with white coat hypertension because it was based upon office rather than home blood pressure measurements. This can be illustrated in the HEP trial, in which 55% of patients fulfilled the criteria of white coat hypertension, and they showed the same magnitude of blood pressure reduction, and they showed the same cardiovascular benefit and mortality benefit. So we have two schools. The American school recommend if we confirm this is a white coat hypertension, do not give treatment, just follow up the blood pressure every year. And we have the European school that give class 2B recommendation level of evidence C to give blood pressure, to give antihypertensive medications for those patients with increased cardiovascular risk and comorbidities. How to evaluate patients with white coat effect? Those patients on treatment and elevated blood pressure at office and normal at home. All patients with increased cardiovascular risk profile should be evaluated for elevated blood pressure at home using ambulatory blood pressure or home blood pressure measurements, as well as those patients who give symptoms hypotension at home despite elevated blood pressure at office. How to manage those patients with white coat effect? Home blood pressure, ambulatory blood pressure, confirm with ambulatory blood pressure, then re-intensify the medications. Now to the management of muscular hypertension. This is a very difficult entity to diagnose. The American guidelines give class 2A to assess for uncontrolled muscular hypertension, not muscular hypertension, in those patients, again, with mildly elevated blood pressure, to those with blood pressure just below the target at office, because at home they may have a higher reading. So those patients with 120 to 130 systolic, 75 to 80 diastolic at office, investigate for white coat for muscular hypertension as they have high cardiovascular risk. So patients with a high normal blood pressure, patients with increased cardiovascular risk, patients without target organ damage, and those patients who have repeatedly elevated blood pressure at a single visit. We measure the blood pressure at office several times, and when it is fixed without decline, and it didn't show variabilities, this is a good clue for muscular hypertension. In white coat hypertension, we will find decline in the reading when the blood pressures are repeated during a single clinic visit. This is a very good clinical practice. Also, some patients with muscular hypertension will show the elevated blood pressure only at night. So will not depend only upon home blood pressure measurement or daytime, but at night blood pressure, especially in those with CKD and diabetes. How to manage patients with muscular hypertension? Again, with repeated measurements at home, then ambulatory blood pressure. If it is elevated, it is class 2A to give medications, despite normal blood pressure at office. The same in the European guidelines. When to evaluate for muscular uncontrolled hypertension? Patients on treatment, normal office, and I am expecting high out of office. Only when there is increased risk of this possible elevation of the blood pressure in high-risk patients. Only in high-risk patients. And how to manage patients with muscular uncontrolled hypertension? Again, we intensify the medical treatment. So this is my last slide. Despite we are talking on what looked like as different contradictory entities, they have many similarities. Both share the discrepancy between office and out of office blood pressure, the high prevalence, the progression to sustained hypertension, the association with metabolic dysregulation, the necessity for follow-up and lifestyle modifications, and the lack of studies to guide antihypertensive therapies. However, they have major differences in the age group. White is related to old, muscular related to younger age group. The prognosis, it is usually benign in white coat. It is not benign in muscular hypertension, and antihypertensive medication is recommended in muscular hypertension and in selected individual in patients with white coat hypertension. Thank you for your attention.
شكرا دكتور كريم. انا ليا حاجتين عايز اسالك عليهم. اولا احنا عارفين ان السبب المنطقي للوايت كوت هايبرتنشن هو السمباثيك نيرفس سيستم، انما ايه الساينتفك اكسبلانيشن للعكس؟ ليه انا يبقى ضغطي كويس في العياده ويبقى عالي في البيت؟ يعني ايه الميكانيزم بيهايند ذس؟ ده السؤال الاولاني. السؤال الثاني، الوايت كوت هايبرتنشن ده موضوع طبعا انتريجي جدا واحنا كلنا بنتعرض له. المفروض انك انت لما بتقيس الضغط في البيشنت ان اوفيس بتمر ببريكوشنز معينه عشان تاخد الفاليد ريدنجز. فلو انت فولفيلد البريكوشنز دي انكلود انك انت sometimes you take more than one reading، يعني ساعات to take 2 or 3 readings، وبعدين البيشنت gets still higher blood pressure، وبعدين هو بيروح بعد كده يقول لك انا في البيت ضغطي كويس، وبعدين انت عاده you don't start medication from the first visit according to our rules يعني. usually you give him some advices lifestyle changes وبعدين تقول له تعالى لي بعد فتره وتشوف. فانا I still believe انك انت لو البيشنت جه بنفس البريكوشنز اللي عملناها وبالفولو اب واللايف ستايل تشينجز and then he gets high blood pressure in the office I still doubt ان انا to dismiss him without treatment. فايه رايك في الحاجتين اللي قلتهم؟
شكرا لحضرتك على الاسئله لان هي بتنتيل الكومبلكسيتي in the diagnosis and management of hypertension in general. بالنسبه للميكانيزمز in one or two words it is complex and unknown. احنا بنعتقد ان الوايت كوت هايبرتنشن سببه ان we have sympathetic at office and lack of this sympathetic at home. However, some patients, many patients lack this evidence for sympathetic stimulations. And there is another theory that there is lack of sympathetic, not increased sympathetic at the home, opposite to increased sympathetic at office. فالميكانيزم till now it is unknown. وحتى الاوتونوميك dysfunction studied thoroughly ونلاقي في الارتكلز اللي بتتكلم على الوايت كوت هايبرتنشن الستاديز اللي بت thoroughly investigate the autonomic dysfunction in those patients are not consistent and not similar to and share similarities to those patients without hypertension. So it is a complex entity. ما فيش clear answer for this. طيب إجابة السؤال الثاني لحضرتك ده مهم جدا اللي احنا الاوفيس والهوم نعتمد على الاوفيس اكتر رغم ان احنا بنفولو كل الريجوليشنز وكل السوفيستيكيتد كونديشنز فور ذا ميجرمنتس. هو الاكشوالي احنا التريتمنت اوف هايبرتنشنز is related to the method that clearly showed reduction in the cardiovascular event when we initiate treatment. This is a fact regarding the number, the threshold, the target, as well as the environment. So we have plenty of evidence that entail us that home blood pressure, out of office blood pressure is more predictive for the outcome when compared to the very good sophisticated technique of blood pressure measurement at office. And ambulatory is more predictive when compared to the home blood pressure measurement. لدرجه ان في بعض الجايد لاينز بتقول انا لو عيان شكيت ان هو عنده وايت كوت هايبرتنشن وطلبت منه يعمل هوم بلاد بريشر ميجرمنتس وجالي بالاجنده اللي مسجل فيها الضغط والضغط بتاعه طلع نورمال I should again ask for ambulatory blood pressure measurements لان الهوم blood pressure measurements بي underestimate the prevalence of sustained hypertension. It is a method for it is the environment and the technique should follow the best predictive tool for the outcome and it is not the office. I will make the diagnosis. طلع وايت كوت هايبرتنشن خلاص. عندنا الامريكان سكول والاوروبيان سكول. الامريكان دايما بيزد على الايفيدنس وعندنا الايجيبشن سكول. الامريكان بيفولو الايفيدنس. there is lack of evidence ان الوايت كوت بيعالج. الاوروبيان لا هم لوجيك لان اغلب الترايلز اللي احنا درسناها 30% اكيد من العيانين اللي دخلوا في الترايل دول عندهم وايت كوت لان هم كانوا بيعتمدوا على الاوفيس. والترايلز بتاعت الهايفت لقوا لما عملوا في الاوفيس والهوم 55% كانوا وايت كوت ورغم ذلك الترايل طلعت بوزيتيف في elderly individual very elderly individual.
يعني ممكن يا دكتور كريم السمباثيك اوفر درايف ممكن يبقى لها كلوز يعني لو في اورثوستاتيك هايبرتنشن دي مع انكريزد سمباثيك درايف لو في اوفر شوتينج للبلاد بريشر مع الاكسرسايز دي برضو بتديني كلو للسمباثيك اوفر درايف، برضو المورنينج هايبرتنشن، يعني برضو ممكن يعني نديفرنشيت.
هي دي كلوز فور ادرينرجيك
يس
دريفن هايبرتنشن اللي نديلها البيتا بلوكرز، لكن هل دي كلوز فور وايت كوت هايبرتنشن؟
بتبقى اسوسييتد،
مفيش
في اسوسيشن.
السيتويشن مختلف.
يس
الوايت كوت هايبرتنشن ده ستريس في العياده، التاني ده اكسرسايز انديوزد انكريس سمباثيك. لان الوايت كوت هايبرتنشن قد يكون سمبل وورد، هي ممكن يبقى ان ذا توب اوف سستيند هايبرتنشن. واحنا شفنا بعض الناس اللي بيجي لهم بانيك ديس اوردرز ممكن البلاد بريشر بتاعه اكسيدز 200 مش 10 اور كذا مليمتر يعني. علشان كده اعتقد ان ال 24 hour blood pressure measurements has a great role in separation of the two condition which will take decision about the lifelong treatment of this patient.
بالظبط.
طيب in order to keep in our time schedule هنشفت النكست. بنشكرك يا دكتور كريم على المحاضرة.